Good morning, chairpersons, professors, and dear colleagues. I'd like to express my special welcoming and thanks to the to the pathology department, hand in hand with the radiology department for such a great work and collaboration. Also, I'd like to thank the previous speakers, Professor Dr. Iman Houidi and Professor Dr. Shaima Abdel-Sattar, for such an interesting topics and talks. And now it's my pleasure to introduce Dr. Shrouk Mohamed Awadallah, the lecturer of radiology, actually one of our outstanding staff. She's going to present us the first case, a radiology case.
Good morning. Okay. Our case will have a QR code scan. Please scan it with your mobile phones to vote for the choice. Good morning, dear professors, colleagues, chairpersons, and our dear guests. Today I'm going to present the first case. It's a 2-year-old girl with a disturbed conscious level. Came to the ER unit with the refusal of feeding and vomiting. Emergency non-contrast CT of the brain was done, and this is the CT brain. As we can see, we can find the hyperdense heterogeneous large mass lesion occupying the posterior fossa. So MRI with contrast of the brain was requested. And on the axial T2 images, we can find a large heterogeneous mass lesion in the posterior fossa with the mixed signal. The axial flare sequence showed that the mass is ISO to low intense signal with the supratentorial mild hydrocephalic changes with no CSF permeation. This is the diffusion images, and we can see the lesion showed the true diffusion restriction. Okay, sorry. The axial T1 weighted images. Pre-contrast showed a large mass lesion with low signal intensity and areas of cystic degeneration, and the post-contrast T1 images showed intense post-contrast enhancement. The sagittal T1 images showed the exact position of the lesion and the mass effect. Also the coronal post-contrast T1 images. So we have a posterior fossa midline mass lesion occupying the fourth ventricle with mass effect on the surrounding structure. What do you think? Please scan this QR code, and it is on your tables. And choose which one of these is your diagnosis. Result, okay. We will talk about each choice in a short way. Okay, the first choice is medulloblastoma, which is the most common malignant brain tumor in childhood. It accounts for 40% of all posterior fossa tumors, and the previous 2007 WHO classification divided the medulloblastoma into 4 histological subtypes, which is classic, desmoplastic, large cell anaplastic, and extensive nodularity. The 2016 WHO classification adds 4 molecular subgroups, which is wingless, sonic hedgehog, group 3 and group 4, which differ in their genetics, prognosis, and demographics. As we can see, the location is very important and has been shown to be a good predictor of the molecular subtype. The wingless medulloblastoma occurs In the CB angle or the cerebellar peduncle, the sonic hedgehog occurs in the cerebellar hemisphere and has a solid component and peripheral cystic component. The groups 3 and the group 4 are midline lesions in the fourth ventricle. One of them is enhancing, the other is poorly enhancing. And the wingless type accounts for 10% of medulloblastomas. Sonic hedgehog, about 30% of medulloblastomas. Group 3 and the group 4 accounts for 60% of medulloblastomas, yet they have a poor prognosis than the first two groups, unfortunately. The imaging characteristics of medulloblastoma on CT, non-contrast CT, they are hyperdense masses. Calcification may occur in about 20% of cases, and some tumors have cysts and necrosis. Hydrocephalus is a common association and common result from medulloblastoma. In contrast, enhanced CT enhancement occurs in about more than 90% of cases, homogeneous or heterogeneous enhancement. On MRI T1 weighted images, the lesion is hypointense. On T2, it is iso to hyperintense. On contrast weighted images, more than 90% of cases enhance, also either homogeneous or heterogeneous enhancement. On diffusion weighted images, medulloblastomas showed restricted diffusion with low ADC value due to the high cellular packing of the lesion. On MRS, it showed low NAA, high choline, high lactate, and elevated taurine. And we should do contrast enhancement of the spine to look for drop metastasis. As in this case, we can see on sagittal T1 and T2 weighted images and post-contrast T1 weighted images, a large lesion in the mid dorsal area posteriorly, and another one here in the cervico dorsal area. The second choice was atypical teratoid rhabdoid tumor or ATRT. It's a highly malignant type of embryonal tumors characterized by alteration of INI1 or rarely BRG1 genes. It is often misdiagnosed as medulloblastoma, sharing the same imaging features, and it can also occur in the CB angle similar to wingless medulloblastoma. As in this case from our hospital, a 2-year-old boy with disturbed conscious level and the secondary inability to walk with blurred disc. The CT showed a hyperdense mass lesion on the right CB angle, and the diffusion images showed the true restricted diffusion, and the flare showed mixed signal. So ATRT showed heterogeneous enhancement with areas of cystic degeneration and hemorrhagic foci. It has more leptomeningeal spread, and it tend to arise off midline rather than the most common types of medulloblastomas. And also the age group is a very important diagnostic clue, as ATRT occurs in a younger age group and it has a more aggressive course. As we can see in this case, the ATRT tends to occur off midline, yet medulloblastoma, most common medulloblastomas occurs in the midline, the fourth ventricle. The third choice was ependymoma. As Dr. Shaima said, it is a tumor occurs in the posterior fossa with criteria or tendency to spread through foramina of Luschka and Magendie, yet it has no diffusion restriction. The fourth choice was astrocytoma. Also, astrocytoma occurs in a cystic or solid nature, and both tends to have facilitated the diffusion. So, if we are looking to a posterior fossa tumor, number one diagnostic clue is the location. If the tumor occurs in the fourth ventricle, we look for diffusion restriction. If there is true diffusion restriction, so it is medulloblastoma. The second location is foramen of Luschka and CB angle. If there is diffusion restriction, we look for the age of the patient. In younger age group, below 3 years old, it is ATRT, most common. In older age group, more than 3 years old, commonly, it is medulloblastoma, common the wingless type. If the tumor in the cerebellar hemisphere, we look for diffusion restriction. If there is true diffusion restriction, so it is medulloblastoma, a sonic hedgehog type, either classic or desmoplastic type. So back to our case, we look again to the case. And back to our choices after we discussed them shortly. And yes, it was medulloblastoma according to your choice. So our take-home message is that medulloblastoma and ATRT has similar imaging features. So the first diagnostic clue is location. If the tumor occurs off midline at the CB angle, it is ATRT. If it occurs in the midline on fourth ventricle, it's most common to be medulloblastoma. The second diagnostic clue is age. In younger age group, ATRT is more common. And please don't forget to image the whole neural axis for any posterior fossa tumor to look for drop metastasis. Thank you.
Thank you, Dr. Shrouk, for your nice presentation of the case and differential diagnoses. We'd better postpone questions to the end of the session.
Now, our colleague from the pathology